EP 101, I guess. So, like I was talking with Mike and John, initially the plan was to talk about atrial flutters, all kinds of atrial flutters, but I thought we'd talk, spend some time on typical atrial flutter, and maybe today just talk only of typical atrial flutter. And at the end of this presentation, I wanted to go back to the last one on ART, talk a little bit about entrainment that we missed, and maybe talk about, a case, kind of just put things in perspective, if you will. So hopefully, I'm hoping that we still get done within an hour. Um, Typical atrial flutter is, in today's day and age, it's CTI dependent counterclockwise atrial flutter. That is the definition of typical atrial flutter as of today. Everything else is considered atypical atrial flutter. The reason I bring this up is because, back in the day when these names were brought out, the definitions were presented. At that point, we recognized only a right-sided atrial flutter. So anything that was CTI dependent counterclockwise was typical, and the clockwise flutter was called atypical atrial flutter. So that's why, if you go back and read some of the older papers, they describe it as, CCW atrial flutter, which stands for counterclockwise atrial flutter, versus CW atrial flutter, which is the clockwise atrial flutter. But like we mentioned in the last talk, we do so much more now. We've got the left atrial ablations that we do atrial tach ablations, and typically any other flutter you see that comes from the left side. It could be the roof or the mitral isthmus or the septum or the left atrial appendage. Those all fall within the realm of atypical atrial flutter. So what I'm trying to get at is typical atrial flutter is a concise topic. It is pretty precise and exact, as opposed to atypical atrial flutter, which could be anything under the sun besides CTI dependent counterclockwise flutter. So today, that's what we're going to be talking about. In today's talk, like I said, I'll try to be as brief as possible, and at the same time, I'll make sure that you guys understand the mechanism and concept. We need to understand the mechanism, like we talked about. Basically in EP, when we talk about tachycardias, we're talking about the automatic nature of tachycardia, the focal nature, or the reentry mechanism. When we're talking about atrial flutter, and I'm going to use the terminology CTI dependent flutter. Basically, CTI dependent flutter is nothing other than a macro reentrant atrial tachycardia. Again, I'm not throwing this term to confuse you, but it's basically to explain the mechanism. And that's the reason why we're so successful in terminating this tachycardia. So in EP, it's all about understanding the mechanism. Once you understand the mechanism, you know exactly what to do. And that also dictates the success of procedures. When you know it's reentry, the chance of success is pretty high. In this slide, like I mentioned, you see the clockwise and counterclockwise, these words, but like I talked about, we're going to be discussing counterclockwise CTI dependent flutter. So this is basically how we're going to go about the talk today. Mechanism we know already. Anatomy, I think that's key, and you'll see why. EKGs, yeah, most times, as physicians, when we see an EKG, we can almost always tell if it is true CTI dependent flutter, if it's not, versus something else. Fluoro, yeah, it's important to also understand the anatomy on fluoro, and I'll tell you why. Some labs, the smaller labs, still depend a lot on fluoro, and I had this one case where we're just starting up the lab, and they hadn't got the ice machine, and in that case, I was fortunate that I understood fluoroscopy to a certain extent, because that's all we did. We did ablation completely under fluoroscopy. Testing and of course therapy is ablation. So what is atrial flutter? Now, okay, let's go back in time a little bit. Again, when I was in med school, the way we differentiated atrial tachycardias were of course, the atrial tachycardia, then we had atrial flutter, and then atrial fibrillation. Of course, none of them hold true completely in today's day and age, like I said. But what we were taught was if the rhythm or the rate was between 100 and 200 beats a minute, call it atrial tachycardia. If it is between 200 and 400 beats a minute, call it atrial flutter. And anything above 400, call it atrial fibrillation, of course. The ablations that we do with all the medications we use, this definition does not hold water at all. But that kind of gives you an understanding and an idea. The main reason we see the difference in because of the purchase area. Think about it. You know, in atrial fibrillation, you're talking about small circuits, typically within the left atrium around the pulmonary veins, as opposed to atrial flutter, where you're talking about, you know, the CTI, which is a larger area. So that's why it takes more time to travel from point A to point B. And typically that's why they said the rates were slower in atrial flutter as opposed to atrial fibrillation. Again, like I said, by no means it is the definition, but just kind of gives you an idea. Flutter, because there's enough evidence, there are enough studies out there that consider atrial flutter or prove that atrial flutter, with atrial flutter, there's a high risk for embolization, you know, for strokes. The way I explain it to my patients is that flutter and fib are two sides of the same coin. You know, what I tell my patients is if it's coming from the left side, meaning the left atrium, I call it atrial fibrillation. If it's coming from the right side, it's atrial flutter. Of course, again, this is not set in stone, but it helps, you know, my patients and get a better understanding of what, you know, what I plan for them or the kind of ablation that I would be doing on them. With all of the tachycardias, SVTs, especially, you know, these impulses also need to go through the AV node. And with the decremental properties, physiological AV node decremental properties, this can go anywhere between, you know, just looking at the last statement, 2 to 1, 4 to 1, 5 to 1. Doesn't really mean much, but that being said, the caveat is if we see an EKG where you see typical flutter waves, but the QRS, I mean, think about it, you know, with physiological AV node decrementation, the distance, if you will, from one QRS to the other will be variable. That's why we call it varying conduction. But if it's slow and if it's regular, then that would suggest infrahisian AV nodal block. And that's really important because in these patients, once we ablate the flutter, guess what? They're profoundly bradycardic, and a lot of them end up with pacemakers. I want to throw it up there because there have been times when I've been sent these EKGs where the atrial rate is say 200, you know, and it's this typical sawtooth pattern as we call it. But the R2R or the ventricular rate is like 40 beats a minute. And the patient's symptomatic. We always caution the patient that, hey, you know, we'll do the flutter, but there's a good chance you'll end up with a pacemaker. So that's something, you know, we need to realize going in, because at the end of the case, you know, it's not a complication of the procedure, but it's something we were expecting. So this is a map, as you can see, a 3D map of atrial flutter. As you can see, you know, as I call it, the head and the tail, or the exit and the entry point, if you will. Again, just to reiterate, 200 to 300 beats a minute, typically, that's what we see. In the past, we would always try to induce atrial flutter, but now if you have an EKG which shows this, you see where my arrow is pointing at, this is typically the inferior leads, and put this into perspective on this map. Okay, so think about it. Lead 2 over here, lead 3 and AVF, so lead 3 over here, and lead AVF right at 6 o'clock. So you got the 3 inferior leads. So the reason you see the sawtooth is because this is how it goes, correct? So it kind of goes in this fashion. counterclockwise. So the vectors are all directed towards inferior leads, and that is why we get such a deep negative wave. And that helps us, that gives us a better idea. This is prototypical for CTI dependent flutter. So like I said, counterclockwise mechanism is almost always what we see. In some cases, we see clockwise. Truth be told, it doesn't really matter in the EP lab because it does not change the nature or the type of ablation that we would be doing. But it does help you know, for teaching purposes, if you will. It also makes great questions on board exams. And, you know, it also gives us an idea of what to expect in the future, if you will, if we see something out of the ordinary, especially in patients that are on, you know, antiarrhythmic medications or who have had ablations in the past. Any questions so far? And again, like I said, you know, feel free to ask questions anytime in between the presentation as well. Okay, so this is an interesting slide. Again, we don't use this kind of nomenclature anymore. You know, back in the day, we'd call it type 1 and type 2 flutters. Right now, like I said, when we talk about flutters, it's either typical or atypical. But just for you know, for discussion purposes, type 1, as you see in the slide, typically was a faster kind of atrial flutter, and most often than not, it was it included the counterclockwise flutters, and more importantly, you know, most importantly, I should say, these flutters are entrained. That's what tells you gives you an idea of the mechanism. So let's look at the anatomy first, and this is well, it's a busy slide, but then it's arranged in chronological order, if you will. It kind of shows you pictures of the right atrium along with the appendage, the SVC and the IBC. So this is obviously the right atrium placed flat on a surface, and I'm trying to look at the money shot, if you will, trying to look for the CTI. And maybe if you look at this image down here at the bottom, this probably will, and imagine the prior slide, this one, okay? So what I'm trying to do is show y'all this image on the specimen, and it's actually an amalgamation, if you will, of these two images. So again, it's hard to imagine a three-dimensional anatomical picture looking at a one-dimensional image, but this, what I'm trying to circle, that is kind of the CTI, if you will. You see, it says the tricuspid valve annulus. So try to imagine, I just moved my pointer to the next image. Try to imagine the CTI kind of in that direction, and you know, and kind of going this way. I wish we had LAO and audio images, but over here again, it kind of shows you the CTI, but not a three-dimensional picture. But essentially, what I'm trying to do is show the circuit, which is a reentrant mechanism, as we all know, that goes around the tricuspid annulus, the atrial port of the tricuspid annulus, with it, and from there it takes off to the atrial septum and goes around the free wall and then comes back to the tricuspid annulus. Again, it's hard to explain that on a one-dimensional picture. It's always easy when you have an anatomical specimen or a model in front of you, and you know, it just takes a second to explain that. But hopefully, you know, try and imagine, again, going back to here, this were the tricuspid, imagine this as the tricuspid part of the annulus, kind of going up around the septum, just below the crista. Again, not the crista, of course, but just to make things simpler, free wall and back to the tricuspid annulus. And what we do is through the right femoral vein or the left, we go in there, put in a catheter that kind of hooks around this CTI, as we call it, the cavo-tricuspid isthmus. It hooks around this, so it goes from the inside, and then imagine it coming out here, and we hook it around the tricuspid isthmus, and then we create this line of block. Hopefully y'all got that, but maybe, when all this blows over, I can show you, or Mike or John can show you a model, and it'll make so much more sense then. So like I said, just to reiterate, it is a wavefront that rotates between the tricuspid annulus. So the tricuspid annulus is where the RV and the RA, the IVC joins opens into the RA, and that leads to the RV. And that's the anterior barrier. The posterior barrier is the other part, or the eustachian ridge. Yeah, like it said over here. That probably, hopefully that, you'll get a better idea of what I was trying to explain with that anatomy. So I'm trying to emphasize the anatomy because that's all it takes. Once you understand the anatomy, on the ice or fluoro, if you don't have ice, you know exactly where the ablator needs to go and what needs to be ablated. Like you said, EKG, we always look for the inferior leads. I told you why. And the other leads we also look for are the lateral leads, the one in AVL. Now, in modern electrophysiology, if you see inverted or negative P waves in one in AVL in someone that has been ablated before, we almost thinking that it could be left-sided. I'm not saying it always is, but that's what, that's our thought process. And the caveat is it could still be typical flutter or, but it's just that based on these waves, we need to be prepared. So if I see an EKG which looks like the typical flutter that I just described, but in one in AVL, it's negative, and the patient has a history of prior ablation, then when I'm talking to the patient about the ablation procedure, I always tell them there's a small chance we may have to go left-sided, or this could be from the septum. Because think about it, in someone where the heart's not really enlarged, a mitral isthmus flutter could mimic a CTI-dependent flutter. It's just, it's the mirror images, if you will. It's one's a left-sided flutter, one's a right-sided flutter. We also talk about these SDT changes. Again, I don't think you need to be bothered about those, but as a physician, when we see that, there's sometimes, it can mimic an ischemic event. And that's something, we tell the patient, if they've not had a stress test or something, we always get that done. So this probably will help a little more. Again, this is the LAO pictures that I was, talking about a little while ago. And so let's focus on these LAO images first. And these just talk about the directionality of the flutter, but essentially, like I said, whether it's counterclockwise or it's clockwise, it's not going to change the type of ablation that we do. We're going to be doing CTIs. And now if you can look at both these X-ray images, if you will, it doesn't matter if you're looking at the one on the left or the right, but focus your attention on ABL, that's the ablation catheter. So remember in the last slide I was telling you, we come through the femoral vein, through the IVC, and then the ablation, the distal part of the ablator is hooked around the tricuspid annulus, or the CTI, in this case, CTI to be more precise. So that's what we do. We hook it around that and then we drag it back. That's how the line is created. Of course, before we do that, I always mark the his to make sure that we're ways away from that. Almost always we have a CS catheter because that helps with the pacing maneuvers, and you'll see why. So this makes a whole, you know, put what I said a little few minutes ago and put this together, and this should make a whole lot of sense. Now, let's go to the anatomical. So go to the figure annotated A. So again, try and superimpose this image on the anatomical picture, and it'll make a whole bunch of sense. You see the CTI? So again, this is a one-dimensional picture. So the CTI is just a line, okay, one-dimensionally speaking. And all we got to do is create this line of block. But like I said, it's important to ascertain where the CTI is, else you'll be ablating till the cows come home, and you're not going to achieve success. So anatomically, it's really important because in some folks the heart is rotated, some folks the heart is hypertrophied, or they just have station ridge. That's the ER over here. So in some cases, we got to go a little lateral. The problem with doing a lateral ablation is that the tissue is much thicker. You got to go a lot more territory, if you will, and the ablation takes a little longer, as opposed to ablating it on the medial aspect, where it is a little smaller, the area that I'm talking about. But when you go a little medial, guess what? You're closer to the his. So the chance of something bad happening is a little higher. Not only that, there's the left circumflex artery that kind of courses around this. You see the halo catheter? I haven't seen this in a while. The last time I used this was probably 10 years ago. Almost none of us use it anymore. It's really helpful, don't get me wrong, but we just don't use it. I think it's fallen out of favor. But go around the halo catheter, and just about a centimeter away is the left circumflex artery. I'm sorry, I said the left circumflex. It's the RCA. I misspoke. The RCA, the right coronary artery, goes right around this. So the reason I like to go a little more lateral is because the distance between the tissue, you remember I said it's thicker? Because it's thicker, the RCA is a little ways away, as opposed to the medial aspect where the RCA is a little closer. And that's something that's really important. In fact, I had a case on, I want to say a couple of months ago, where the fellow was doing the ablation, and beautiful single line got blocked, flutter broke. We're done with the case, kind of scrubbing out, and about 5 minutes later, the patient coded. And long story short, we did a heart catheterization, and the distal RCA around this area was completely spasmed, almost occluded. Of course, he made a full recovery and whatnot, but scary times. And that's the reason why I like using the ice, because even with the ice, you can look at the RCA and kind of delineate it on the map, so you're ways away from it. So this is a nice EKG. So straight off the bat, if you look at it, it's tachycardia, but it doesn't show the prototypical P waves. That being said, Mike, John did a good job of kind of blowing this picture up, enlarging this picture. And as you can see, it's almost a 2-to-1 tachycardia. And where you see these arrowheads, it's actually this is kind of out of focus or misaligned, but this is the P wave you're looking at, and as is this one, and this one. So over here you can see it does fall, within the realm of the CTI dependent atrial flutters. So again, this just reiterates what we've been talking about all this time. Counterclockwise over here, this is pretty typical. And once you've seen a few of these, the next time you see another one, you'll be like, okay, this is CTI dependent flutter, unless proven otherwise. And that's the reason why, even if we've seen something like this in the office, we plan the ablation, and for some reason, say the patient's on meds or they spontaneously convert, we don't need to re-induce before the procedure. All we do is a CTI, the ablation line, and at the end, we always do our pacing maneuvers, isopropyl and whatnot to see if it comes back. Now, so these two on the left are the prototypical counterclockwise CTI-dependent atrial flutters. But if you look at this one on the right, focus on only these two leads, 2, 3, and then AVF, of course. But just for for sake of ease, look at leads 2 and 3, and you can see straight off the bat it does not look the same. So of course you're thinking it could be a left-sided flutter. And if you look at AVL, it's not really specific. So you don't know what you're dealing with. So this is the patient in whom I'd be like, okay, if they've never had an ablation, we'll be like, yeah, sure, it could be right-sided flutter, but be prepared in case we got to go left-sided. If you get it on the right side, you're done. Everyone's happy. But if you don't, then of course, then the usual suspects go after the mitral isthmus, the septum probably, or even the floor of the left atrium. So this is just, like I said, this is back in the day when we used to put the halo catheter. Gives us a lot of information, because it, if you recall that slide that I showed, it gives you data points from the entire right atrium and along the entire CTI. And truth be told, if you have the halo catheter, use it, because you know exactly when you're ablating, the flutter terminates with the halo catheter, for sure whether you've achieved block or not. So this just kind of illustrates the halo catheter, the CS catheter, and the ablator. But like I said, the way I do my CTI is I typically just have two catheters. I have the ablator and the CS. And what I'm doing is I'm pacing from the CS, either the proximal or the distal, depending on where it's located. Of course, almost always from CS 910 if it's proximal enough. And I'm dragging the ablator along the CTI. So we'll come to this in a second. So this is obviously a map of in the EP lab of atrial flutter. As you can see, we have flutter going, and this is a nice animation of the directionality of a counterclockwise CTI flutter. Okay. So let's do this one at a time. What we're doing is entrainment in this slide. Okay. So as you can see, hang on, let me. Oh, so this is with my mouse. So as you can see, we're trying to entrain the tachycardia. So rule of thumb, when you have a tachycardia, whatever the tachycardia is, 250, 300, 350, typically we go about 10 to 20 milliseconds below that in an attempt to entrain. That's the rules in entrainment 101. If it's faster, like 220, 230, then I probably drop it by about 10 milliseconds. If it's a little slower, within the range of 300, 350, then I probably drop it 20, entrain it once, then I drop it 10, and I entrain it again. So like I said in my past talk, it's always reproducibility. Okay, so in this case, the tachycardia cycle length is measured at 298, and we're entraining at 270. And over here, the way we look for entrainment is the last paced beat. So you measure that, excuse me. And what I say is be consistent. So it doesn't matter if you're going through CS 910, 7, 8, 5, 6, 1, 2, it doesn't matter. As long as you're being consistent and you're measuring the same points in time. That's all you need to do. Excuse me. And over here, as you can see, the last beat has been entrained, and the PPI minus the tachycardia cycle length is what we're looking for. From the last entrained beat, it's been measured for us. So if you do the math, the 316 minus the 298 is less than 30 milliseconds. So let's go back. Okay, and talk about the principles of entrainment. What I just demonstrated through that illustration was entrainment. So hopefully this slide will make a little more sense. So firstly, there are two terms that you need to be aware of. There's something known as manifest entrainment, and there's something known as concealed entrainment. So the way to remember it, again, there's a definition, and of course, this is the right definition that you see on the slide, but to make it easy, concealed, when you've performed entrainment or when entrainment has been performed in the lab, and the EP doc says, okay, I think the tachycardia is entrained, the resulting morphology, if it is the same or is similar to the tachycardia, that's concealed entrainment. If it looks different, then that's manifest. Again, it's not set in stone, and there are lots of caveats and there are lots of ifs and buts, but this is one way of looking at it in the cath lab. Because when you see the morphology completely different, then you know it's manifest entrainment. That helps a lot when we're doing VT ablations. But let's focus on the slide for a second. So what is entrainment? It's a technique we use in the lab where we try to capture or reset the tachycardia. And it's one of the most common maneuvers we use in the EP lab. By doing this maneuver, what we're doing is we're identifying the mechanism of the tachycardia, and we're also identifying the location of the tachycardia. How do we do that? Firstly, like I said, you pace a part of the heart, in this case the RV, at a constant rate to identify and reset the circuit. Once we do that and we stop pacing, we look for the PPI and tachycardia cycle length. Like I said, if it's less than 30 milliseconds, that by definition tells you that you're within the circuit and you're at a good spot to ablate. And more importantly, anatomically speaking, you're in the right area. Just to give you an example, I'm sorry, just to explain that further. So if you're pacing CS 910 and you entrain the tachycardia, as in, and the PPI minus tachycardia cycle length is less than 30 milliseconds, you're within the CTI area most likely, and that's what you're going to ablate. But what if that is more than 30 milliseconds? The two possibilities. One is the catheter is not in position. Of course, you look at that, adjust that. But assuming the catheter is in the right position, and the pacing cycle length is off, as we call it, that means it's outside the circuit, and that could be one of two things. One is it could be you've not entrained the tachycardia accurately, or it's just coming from a different spot, and that different spot could be a mitral isthmus flutter. And that's the reason why when I do these pacing maneuvers, entrainment maneuvers, I always start at different sites. So I start at, say, the high right atrium, which in a CTI is going to be off. So the PPI tachycardia cycle length will be 70, 80, 100, who knows, but it's going to be more than 30, as opposed to CS 910, which will be closer. But the most accurate thing is to place the ablator on the CTI and attempt to entrain from there. And when entrainment is successful, then almost always, in fact, I would say always, the PPI minus TCL, the post-pacing interval and tachycardia cycle length difference is less than 30 milliseconds. So if you focus your attention and kind of put whatever I said, use on the left, on this left image, you'll see that the PPI tachycardia cycle length determines that it's within the circuit, as opposed to the one on the right image where it's outside the circuit. So if you look at the annotations below, it kind of tells you the same thing. So the image on the left is a CTI ablation. I'm sorry, it's a CTI dependent mechanism and all you got to do is ablate the CTI. But the image on the right is not CTI, and then you got to keep looking. A thing that I commonly do is if something's off, I paste from CS12, which is distal. So this is the CS910 is say somewhere over here, and CS12 is, is closer to the mitral isthmus or
Looks like we lost Dr. Mukerji, huh?
I didn't know if it was me.
Mike, so pacing from the CS910 indicates.
any questions so far? Does everyone understand the concept of entrainment? It's not something that you get on day one. Of course, repetition is key and reinforcement too. But kind of working on these lines will make and kind of seeing more and more of these EGMs will explain it and hopefully make things easier. So this slide, and again, I'm just pushing forward. I'm not sure if y'all are paying attention, but just kind of reinforces. EP is all about reinforcement and repetition. So just kind of put things in perspective, like I was talking about, just everything what I said in the last 10 minutes, this slide kind of explains everything really well. So like I said, the tachycardia cycle length 270, I'm sorry, tachycardia cycle length 298, where pacing cycle length is 270. We entrain the PPI minus tachycardia cycle length is 316. When you do the math, it's within 30 milliseconds. So you know you're at the right spot. As opposed to the next slide where the circuit is off. And in this case, what I would do is, since we know it's off, I would paste from CS12. And if that was on, then I'd probably go transeptal and start looking at the mitral isthmus. Not always, but of course, something left-sided. Could still be the septum, could be the roof, like I said, it could be the posterior wall. But typically, if you've been trained and if it's off, you got to do some of the maneuvers. And again, a good view, LAO, that's, historically, that's how we were taught. That's how I was taught when I started doing ablations. Kind of go LAO, go to about the 5 or 6 o'clock position, as you can see, tip of the ablation catheter. Encompasses the entire atrium. You have this over here, and the only two catheters I use are this. Anything else? Of course, if it's a CTI that in with the PI, at that point I have an ICE catheter, and I call it a one pass. If I don't get a block in one pass, if I'm only doing a CTI, then I pull out the ICE catheter and take a better look at the anatomy. And sometimes there's a thick eustachian ridge, or the anatomy is just rotated, in which case this ablator, I'll move it closer to the 7 or 8 o'clock position. So again, this is a picture of the 20-pole catheter. We don't use it much in today's day and age, but if you look at the bottom, that's what I call the concentric pattern of activation. And let me see if I got a better slide. Unfortunately not, but then yeah, like you said, what we're looking for is a concentric pattern, similar to distal. So CS910 followed by 7, 8, 5, 6. You get the drift. So these are just different maps of tachycardia, and it's just giving you different points in time or different points on the map, basically to give you an understanding, because sometimes there's some operators that just map the tachycardia, especially when you don't have other information. So you're doing say an operator has got just catheters inside and is doing an EP study, and they induce a tachycardia, and that specific operator wants to map the tachycardia using a three-dimensional mapping catheter, and we're not really doing any entrainment maneuvers. So in those circumstances, all we do is try and map the entire length of the tachycardia, and then based on the different colors, if you will, you can identify it as a CTI. And that's happened to me also a couple of times when I'm not sure what's going on. It looks like an atrial tachycardia, or a young person, I'm not expecting CTI dependent tachycardia. We induce a tachycardia at about 200 milliseconds. We're not sure what's going on. We map the tachycardia and it turns out to be CTI dependent tachycardia. And at that point, of course, to confirm, I would do entrainment maneuvers, not that it's needed, but just to confirm that it is truly CTI dependent flutter, and then go and ablate it. So, like I said, in EP, there are always exceptions and always exceptions to exceptions. When we talk about CTI dependent flutters, almost always the success, 97 to 99% of terminating. We always look for block. But before we go into that, there could be other CTI dependent flutters, as in, we've mapped the tachycardia, we've entrained the tachycardia, we've shown that it's CTI dependent, but sometimes, even despite doing all the ablation, we don't get complete block, or we're not being able to terminate it. In those cases, obviously, we're looking for different other tachycardias, but sometimes, there is something known as low loop reentry, where the tachycardia looks, smells, and follows all the other characteristics of CTI dependent tachycardia, because anatomically speaking, it's right there. But from an ablation standpoint, we're not at where we should be. I mean, we're still doing the CTI, but we've got to be closer to the IVC, because that's where the circuit exists, if you will. And this is mainly because it's going around. If you go back to that anatomical picture I showed of the around the crista and the posterior free wall, the breakthrough is right over there. And sometimes ablating at the IVC, the spot of the IVC, obviously we got to be really careful, or going a little lateral, or even closer to this crista may end up terminating the tachycardia. Again, a lot of times, I'll be honest though, if we're lateral enough with the ablation catheter, this almost never happens. And also, when we ablate closer to the IVC, the spot, the drop, as I call it, we almost never see this. The intra-isthmus reentry, yeah, this is something we can see in this kind of tachycardia. Again, it's a part of the CTI, but it's more around the medial CTI and closer to the CS. And truth be told, this happens more often than we believe it to be so. We just probably don't recognize it because we're ablating, at 35, 40, sometimes even 45 watts, and the catheter is kind of, going from the lateral aspect to the medial aspect. So we're covering the entire area. A lot of times, if it doesn't terminate, we go a little more lateral or a little more medial. Truth be told, this happens a lot more often than we believe it to happen, and we just don't see it because, by virtue of ablating in such a big area, in addition to the CTI that we've run, we end up, achieving success. This is just for completion, cardioversion. There are other medications. Again, like I mentioned to y'all before, unless you're, addressing the circuit, we're not really fixing. We're not really fixing the problem. Now, the sheets, historically and traditionally, we've been using the SRO sheets. That's what I've been using. More recently, I've started using the ramp sheet. Again, I'll have Mike and John show you all what those different sheets are. So if you look at the ramp sheets, the SRO kind of, if you look at my index finger, kind of it's got this subtle bend, if you will. So the catheter comes out of the sheath and then we got to physically bend it more. The ramp sheath kind of is like a hook. So think about it. When you've got this sheath and the ablation catheter just sticking out of the sheath, that's not moving anywhere. So that's the reason why a lot of us prefer doing that using the ramp sheath, because once you get it in there, you got it on the CTI, all you got to do is drag it along the CTI and the success is phenomenal. But that being said, if there's a lot of wattage being used and if you're close to the RCA, bad things can happen, like I pointed out. So this is an anatomical picture again of the atrial flutter that was ablated along the CTI. I'm not sure if it helps, but kind of, that's your CTI. Again, I don't really like these one-dimensional pictures because it doesn't really put things in perspective. So this is what we're looking for. That's the key terminology. You will hear this almost always in the EP lab. We're looking for something known as bidirectional block. So what is bidirectional block? It's pretty simple. Again, go back to when I said I used 2 catheters. Okay, so I've got one catheter in the CS, and the second is my ablation catheter. Okay, so I've drawn a line, and I'm making sure that my line is blocked when I'm pacing from both aspects, from the CS and from my ablator. So imagine two points. One is the CS, proximal CS, and the other is the ablator. So I put my ablator on one side of the line. So, okay, just to explain things. So imagine, if you focus your attention on the pointer, imagine this as the line. So I got my CS on the right side of the screen and my ablator on the left side of the screen. So I pace from one point and I see how much time it takes to reach. So point A to point B. That's one direction. And then I do the same thing from point B to point A. And when there's block from pacing from both points, point A and point B, that is what's called bidirectional block. So the magic number is 120. There have been enough studies to show that if you've achieved 120 milliseconds or more, that is block. So if it's 121, or if it's 151, or it's 181, it doesn't really matter. Studies have shown that it is 120 milliseconds and above is what's needed, assuming that both those points are accurate anatomically speaking. Of course, we've done ablation long enough to realize that we prefer, maybe we're just so anal that we prefer, the longer the block, it gives us more satisfaction. But truth be told, if you got a block of 120 or more, you're golden. And that's exactly what we're measuring over here. So just, we again have the halo, but just imagine point A to point B. So we're pacing from point A, and we're measuring to point B, it's 153. When we see that, we're like, okay, we've got block. Then we do the same thing backwards, and we're looking for block. So the other thing we talk about is the direction of block. Honestly, that doesn't make that much, that doesn't play that much of a role for CTI blocks. That's more important for mitral isthmus blocks, and we'll address that when we talk about mitral isthmus ablation. But that's essentially what we're talking about, bidirectional block. The other thing I personally do is something known as block on differential pacing. Okay, so I'll use the same picture, if you will, for ease of demonstration. So like I said, you've got point A, see where my cursor, my pointer is, and then say this is point B. Okay, and we established that is 120 milliseconds. But that is across this point of the line only. What if there's a leak over here? We don't know. So what I do is after I confirm bidirectional block and pacing, I put my ablator a little higher. And then I do the same thing, point A to point B. Now, think about it. If this takes, say, 130 milliseconds, this is going to be shorter. Now, how short is short? I use the same, 120 milliseconds. If for some reason, point A to point B over here is short, like 60 or 70 milliseconds, I know I still have to ablate. What I'm trying to establish is the differential pacing principle that I was talking about. So if I show that point A to say point B over here on top is short and point A to point B over here is long, that is what I mean by differential pacing. For some reason, if the numbers are off, like if I say that point A to point B is say 120, and then I take it up here and I say point A to point B is 90. Though we've achieved block and differential pacing, we've probably not achieved bidirectional block. But if I demonstrate point A to point B up here is say 120, and point A to point B down here is say 125, the purists may say that you've not achieved block, but I say that you've achieved block on differential pacing and you're done. You see, again, this is not an easy concept. So if you have any questions, please feel free to ask. But this is basically what I call the endpoints of ablation. And when I've achieved differential block and bidirectional block, I can say that my ablation is complete. And truth be told, I don't even do any more pacing maneuvers or try to reinduce because, like I said, by definition, ablation is complete, block is achieved, we're done. Any questions?
Hey,
Yeah, so when you go higher and you're checking to make sure there's not a leak or that it's not shorter, does it still have to be strictly over 120?
No, and that's what I said. So also the other thing we look for, when we're ablating, there's something we look for known as double potentials. Okay, so if you look here, that's what if I have. So just imagine the ablator, these signals to be on the ablator. Okay, this is what I call a double potential on the ablator when it's on the line of ablation. So this demonstrates a delay in conduction. So if the distance between point A and point B is more than 110 milliseconds, that again is indicative of the ablation being complete. To answer your question, for differential pacing, there are no set numbers. What we're looking for is when you're at a point that is higher from the point that you're checking, if that's short, and there's no definition for short, as compared to the regular point that you're checking. That's what I mean by differential pacing, because sometimes it's the same. So if I'm checking point A to point B and point B is higher than the actual point B, if both those times are the same, then we've not achieved block on differential pacing. But to answer your question, there's no for differential pacing, there's no number that has been given. But the other numbers are for bidirectional block, which is 120, and double potential, which is 110 milliseconds. So if we've achieved both these, you've achieved 2 out of 3 in a sense, you're done with the ablation.
Thank you.
You're welcome.
how long do you normally wait, Mukerji, after you have bidirectional block?
Honestly, if I've got, bidirectional block and differential pacing and even my double potentials more than 110 seconds, I'm done. I don't even wait. I pull catheters out and we're like, yeah, end of case, end of procedure. In some cases, I may use, Atrial, or especially in someone that has not had documented CTI flutter, someone that comes from an EP study and then we induce flutter and we ablate it. Those patients, I may do Atrial, I may do some pacing maneuvers to see if it comes back. But if it's only flutter going in, almost never wait.
Can you talk a little bit about the difference between pacing for entrainment and pacing for ATP for termination?
You mean ATP that we use for devices, or just that we use during? Are you talking about ATP that we use
Primarily for devices, but you could do it in an EP study too, I guess. But that can be a little bit confusing.
Yeah. Okay. So entrainment is a whole different principle, if you will. So in entrainment, the first rule of entrainment is you're trying to capture the tachycardia, for lack of a better term, and you do not want to terminate the tachycardia. So it's apples and oranges. So that's why I'm not sure I understand your question, John. When we entrain, we're not trying to terminate the tachycardia. We're trying to establish certain ground rules, if you will, and we're trying to identify the mechanism and the location of the tachycardia. And it's a principle, it's a diagnostic maneuver. The ATP that we use, or the what you're talking about, is the overdrive pacing that we do to terminate a tachycardia. And I do that a lot in someone that has an unstable tachycardia, say VT, or even if we induce a tachycardia and the patient, drops the blood pressure or goes hemodynamically unstable, even if it's atrial tachycardia. In that case, we overdrive pace. So I'm guessing the question you're trying to ask is, what's the difference between entrainment and overdrive pacing? And that's there are a few rules, like I said. In entrainment, what we're doing is, firstly, we don't try to terminate the tachycardia. We're pacing at about 10 to 20 milliseconds below the tachycardia cycle length. We're trying to, like I said, capture the tachycardia and establish if this truly is a re-entry mechanism. So that's why we look at the last entrained beat. In overdrive pacing, what we're doing is we're just pacing faster than the tachycardia in an attempt to terminate the tachycardia. Sometimes entrainment leads to termination, but that's not entrainment. There are 4 caveats that we always have to look for in RV entrainment. Like I was talking about, but that again is a whole different talk. And if you want, I can talk about RV entrainment maybe at a different day. But what John, I think, is trying to differentiate between is RV entrainment and overdrive pacing. And maybe, we can just do a separate talk on this. It won't be a long talk, but we got to have slides and we got to go through the principles of entrainment. And this is probably the first thing that we teach all our EP fellows, because a lot of times RV entrainment and overdrive pacing kind of get, get mixed up, if you will. But we'll leave it for
the timing and location of where you're pacing from.
I'm sorry, say that again.
I say basically it's a difference in the timing and also
yes
pacing
yeah
from.
Simply put, that's exactly what it is. Yeah. Any other questions?
I had a quick question just about the bidirectional block. Did you say that you would be using the ablation catheter to determine? And
yes.
While you're going through the measurements, if you come across, where you don't have the block, would you immediately ablate?
Yes. Yeah. So typically when we've not, of course, when you're pacing and you're measuring, if it's not within satisfactory numbers, the first thing we say, okay, we've not achieved block. So there are 2 ways of going about it. Personally, what I do is I do something known as a leak map. So what I do is I continue pacing from CS and I move the ablator along the line of ablation. And then I look for, where it's, and of course it's going to be different at different points. Some points are going to be shorter, some points are going to be longer. And of course, the points that are shorter is what I call the point of leak, and that's the first point I'm going to be ablating at. But yes, yeah, typically when I see the block's not been achieved, then the next thing is to find out where the leak is from. If it's from, it's in the middle of it, or sometimes patients have a pouch, and that's probably when I'd use the ice to look for the pouch and then go around the pouch, because it's not easy to ablate in a pouch, mainly because it's a thin structure, and contact stability and the amount of power that is used has to be watched for carefully, because if one is not careful, we could potentially poke a hole in that, and then obviously bad things can happen, like effusion and whatnot.
Thank you.
Yeah, you're welcome.
How much more helpful has the irrigated tip catheters been for A flutters?
In this case, a lot. I mean, I when I started, I was using the 8 millimeters, the Blazer. I used to use that almost always for my CTIs, but since it's a game changer. In the past, we would take 45 minutes minimum, sometimes a couple hours, sometimes longer to do a CTI. But now with the irrigated catheters, in folks that have a short CTI, we're done in like 15, 20 minutes, and it's amazing. It's amazing. I mean, all I have to do is probably use a ramp sheath, 35 watts on an irrigated catheter, and I'm done in 15, 20 minutes if it's good anatomy. Yeah, total game changer. I agree. This is the one time I almost always use an irrigated catheter, as opposed to slow pathways where I still use a non-irrigated tip. All right, so I know I said I'd spend a few minutes on entrainment, but this I feel like there's been a lot to swallow from what we've talked. I did mention a little bit about entrainment. What I would encourage you all to do is probably do some reading yourselves, maybe discuss a little more with Mike and John, and maybe the next time we meet, if you still have some questions, I can show you a few more slides on entrainment, and probably talk a little more on that. And at that point, with those entrainment maneuvers, I can talk about the VAAV response and the VAB response that I didn't talk about when we discussed avian Ortiz. So we'll leave that for another day.
Thanks, Dr. Mukerji. We'd love to have you again next week if your schedule permits.
Yeah, absolutely. Look forward to that.
Thank you so much, Doc.
John. Oh, you're welcome, guys. Take care, stay safe, and Mike and John, we can talk on our next topic. All right.
Sounds good. I'll be in